Hello, everybody. Welcome to today's webinar. Today's webinar is Update on Chronic Care Management Covered Services in RHCs by Dan Godla from ThoroughCare. Hi, this is Mark Lynn with Healthcare Business Specialist, and this webinar is being presented by the Rural Health Clinic Information Exchange. If you've not joined that, we have about 5,000 members. You're welcome to ask questions. You're welcome to post information about seminars, conferences, things like that, that will help rural health clinics, and ThoroughCare is our partner in this webinar. I'll give you a little bit of an advertisement at the very beginning before I turn it over to Dan. Our team at Healthcare Business Specialists is myself, Danny Gilbert, who is my partner, Paige Chambers, who is our RHC consultant, and Trent Jackson. So if you see those names coming from any of the materials, that is our team, and it is legitimate. What we do is we do cost reporting. If you haven't done your cost reports, if you haven't done them yet because it's early, but if you need somebody to do your cost reports, we do a ton of those. Program evaluations and emergency preparedness, you have to do those basically every 2 years. You will get a condition level deficiency if you don't do those things. So if you need that service, let us know before you do get a condition level deficiency, because that's not a lot of fun. I'm heading up to Kentucky next week to solve one of those issues, and it's not fun. This presentation will be on our YouTube channel once it's over with, so you can view that at any time. It will also be posted to our Facebook group. A disclaimer, Dan's information is current as of today. The session is being recorded. The content is provided by ThoroughCare. They will have a disclaimer, but from talking to Dan, it's based upon the current interpretations that CMS has released. And right now, there's a lot of gray areas in the material. The CCM program is not new, but the changes for 2024 are new. They've added new services. There's new ways to do the GO 5111 that you could not in the past. And so, we're in a little bit of untested water. So Dan is the expert in this. When we go to the NARHC meetings in San Antonio and Grand Rapids and all the different locations, you will see ThoroughCare there. So that's one reason why we reached out to them, because we knew they were very strong into the rural health clinic market, so which we appreciate. If you are a certified rural health clinic professional, Healthcare Business Specialist is the first vendor that's been approved by the National Association of Rural Health Clinics to issue continuing professional education credits. This is eligible for 1 credit. If you want to get that credit, you'll have to answer, we're going to have 4 poll questions. You don't have to answer them right, but you do have to answer them. And if you answer at least 3 of them, you will be eligible for that 1 credit. If you do want the credit, send it to Trent. And there is Trent's email there. Tell them that you attended the webinar and would like credit. Trent will look it up in our report. If you answered them, he will shoot you a certificate that will look like this. If you do have questions, you can put those in the question box. If we have time at the end, we'll try to answer as many questions as we can before our hour is up. And the session, the slides will be posted to our Facebook group. They're already there. They're already on our ruralhealthclinic.com website. And if you go over to the handout section, the slides are over there as well. The slides in the handout section, I know Dan's presentation is pretty long and pretty intense. It may not download. If it doesn't, go to our website at ruralhealthclinic.com and you can pull the slides from there, or go to the Facebook group and do the same. About our speaker, Dan is, like I said, he's been doing ThoroughCare since 2013. Really, they are the leader in chronic care management for rural health clinics. So again, that's why we chose these guys. Dan is a 6 Sigma green belt. I don't know if that means he's going to beat us up or something like that if he knows karate, but that sounds pretty impressive. So I know just from knowing Dan and going to the meetings and all that, that he will be fantastic. So before we go into his presentation, I am going to do our first poll question here. So let me go in here, use my old eyes to look at here, and I'm going to launch it. And the poll question, it's open. Do you plan on, do you currently do chronic care management? Do you not do it yet? Or you've not yet, but you're planning on doing it in the future? And it looks like so far 73% of you already have a program going, 11% of you don't have one yet, and 17% of you are planning on it so far. So I'm going to let it stay open. I'm going to give you 15 seconds to count down to get your answers in. 74% of you have voted so far, so you're doing good. But I'm going to give you the 1 minute mark, so you've got 15 seconds to go to get your vote in. Otherwise, we're going to close it out and then get Dan started. And Dan, when you if you get to a stopping point in your presentation, just let me know and say, well, Mark, better a good time for a poll, and then we'll open up and do our next poll. Okay, I'm going to close it. 70% of you have a program, 12% do not, and 18% of you are planning on it. So I'm going to close this out. And let me see here. Now, Dan, I'm going to make you the presenter. And so now you have control.
All right, thank you, Mark. Let me put my slides up there and let me know if you guys can see them.
We can. Very good. Perfect.
All right. Well, Mark, thank you for that great introduction. And hi, everyone. My name is Dan Godla. It's a pleasure to be with you today. Today, we're going to talk about the 2024 physician fee schedule, specifically for rural health clinics. When that big document comes out, there's a lot of confusion sometimes, and I often feel that it makes the best sense to talk through it together, and we'll have plenty of time for questions at the end of the presentation. So without further ado, let's dive in. I'm going to give the same disclaimer that Mark did. This is our interpretation of these rules. I always advise people talk to your own medical, legal experts. We're going to cover some areas today that I know that you'll agree there is a gray area where there's a couple different ways you can interpret things. I'm not going to guide you one way or the other. I'm going to suggest that you do your own research. But CMS, typically what happens if there's areas that can be interpreted different ways, they'll periodically issue clarification and guidance. So we do expect that to happen in some areas. And then on certain parts, I'm going to talk about some national average reimbursement rates. Obviously, rates could be differently for you depending on your geographic location. You could always check the physician fee schedule for specific information for your area. So I'll do a quick introduction, then we'll dive into the final rule for 2024. I always like to do a history of care management programs for RHCs and FQHCs. I'll kind of give a little away right now. That's this year is really good. There were many years where the changes weren't as good or almost non-existent for RHCs. We'll kind of go through how we got to where we are today. We'll talk about what those changes mean for the rates and reimbursements, some new fee-for-service programs for 2024 and why that's applicable to you guys. We'll talk about changes to general care management, our recommendations for 2024. We'll do a quick summary of all the changes, and then, like I said, plenty of time for questions at the end. So as we're going, like Mark mentioned, please enter your questions in the Q&A, and that way we'll have them queued up for the end. Okay, so let's dive in. Mark gave a little intro, but again, my name is Dan Godla. I founded ThoroughCare about 10 years ago. We're located in Pittsburgh. You can see behind me, downtown Pittsburgh. We're about 50 employees. We work with about 700 clinics, and our product is a care management platform. We help groups do a lot of the programs that are hard to do in your EHR, but designed for that time in between patient visits. So we have solutions for chronic care, RPM, wellness, transitional care, and some other programs as well. So today's webinar is not going to be about ThoroughCare. If you do need some software, reach out to our team, website's below. But that's my background. And the reason I I'm excited to do this webinar is because we work with a lot of RHCs. So we've seen almost every scenario you can imagine. We're active in the rural community, so we have a good idea of what all of you are going through. So reach out if you want to learn more, but today we're going to talk about the actual programs themselves. So what is the CMS final rule for 2024 and why are we here today? Well, this large document was released in November, and it's about 2,709 pages. And there's the link if anyone wants to actually go to it, but we're doing this webinar so you don't have to. It's quite a lengthy set of the new regulations. So this is something that CMS issues every year. They first propose it in July, and then there's a comment period where they give everyone 60 days to write comments. I'm actually going to share with you towards the end some of the comments that we made to CMS, and I would encourage all of you to make comments as well. And geez, if there's 700 folks signed up for this webinar and everyone issued a comment, I think that would carry a lot of weight when CMS reads those comments. So definitely encourage you guys to do that. But the information that I'm showing here went into effect January 1st. So, you know, it's mid-February right now. So a lot of you might not even have been aware of some of this, or maybe you submitted your January claims and noticed something was different. So this is a good time. We're still early in the year to get a full grasp on all these changes for general care management. But let's talk about how we got here. So let's take a step back up all the way to 2015. So this is where I like to start the story. And this is where CMS launched a program called chronic care management. And throughout the webinar, we're going to abbreviate chronic care management as CCM. That's typically what we refer to it as today. And this was a new concept. So really before this, clinics were reimbursed when the patient comes to the office. So this was a new trend where Medicare is saying, all right, I know there's a lot of stuff you do between appointments. We're going to pay you to do that. And they created a CPT code 99490, and it paid about $42 in year one. The patient had to actually sign a form to participate. And for you on the call that are RHCs, you could not participate. It was not open to you in the first year. The rules for the program, patients had to have 2 or more chronic conditions, and you had to prove that you spent 20 minutes per month. We'll talk about some of the resources involved later, but at a high level, it has to be a certified clinical resource to do CCM. So a lot of groups use certified medical assistants, or even a CNA could work too. An RN is great too, but it doesn't have to be a provider. These services are provided under the supervision of the provider. Now in 2016, RHCs and FQHCs were allowed to participate, but you had tighter restrictions. So while other groups could outsource to a third-party organization, maybe a group that had clinicians, if you were an RHC, you could not do that. And you had to provide 24/7 access to care directly from your office. So this created a big barrier for a lot of RHCs because you had to have someone answering the call directly in the clinic 24/7. So in 2017, some of those restrictions were removed. So you no longer had to have that 24/7 care in-house. You could operate under the general supervision of the provider, and that means you could work. And that initial visit where they had to sign the form wasn't required. You could do verbal consent as long as they saw you in the past 12 months. Meanwhile, while those restrictions were moved for RHCs, on the fee-for-service side, CMS created some additional codes. So the base code, like I mentioned, you had to get 20 minutes. A new code was created, 99487, that paid you more if you got 60 minutes. And then an additional code if you went over 30 more minutes. So those codes were available to fee-for-service. They were not available to you as an RHC. So I think you might, if you could read between the lines, you could see the trend here is that new stuff comes out, it's not available to you, and then the next year it usually is. So we're not sure why, but I'm not going to spoil it. It does get a little better for you. And if you ask me, in one of these years, I think it gets better than the fee-for-service side, and I'll explain more. But let's go to between 2017 and 2018. Like I said, there's always that feedback period. So we give feedback. Nathan from the NARHC, he shared the feedback they gave this year. we argued that it was unfair to limit RHCs and FQHCs to the 20-minute code, while other groups can do 60 minutes. And so CMS agreed, but it was all about how to do the proper way to collect payment. How do you get payment equity? So that was the proposal, but CMS opted that there should be only one code for the sake of simplicity. So here's the one code, and it's now called GO511, but they increased the rate. So it's interesting what they did here. So CMS said, no, you can't do the 60-minute and you can't do the 30+ minute, but we'll take all the averages of those codes and that's what we'll pay you. So you can only do 20 minutes, but if you do 20 minutes, you get $62 where other groups were getting 42. So there's a very interesting twist on it, but for the first time ever, you get paid more to do a CCM than a typical fee-for-service clinic. So this is the year that that code started to pay $62 for CCM. Now in 2019, the fee-for-service side was updated and a new program called remote patient monitoring, and we're going to refer to remote patient monitoring as RPM, and a new code was created. There was 3 minutes of provider time for CCM, so that's one of the new codes, 99491, and that paid $74.26. However, even though that new code was created, it was not made available to you. But again, CMS did something interesting where they said, well, we're not going to let you bill for it, but we're going to take its reimbursement rate and calculate that into the average. So with that in mind, the 62 was increased to 67. And so now you get 67 for a 20-minute CCM. And like I said, while RPM was created, it was not available to a rural health clinic. And those are some of the RPM codes that were created. Now, this is going to be more important later on when we talk about the 2024 changes, but this is the year that this came out. So, Mark, it might be a good idea while we're talking about RPM, maybe we could put up another poll to see if any clinics would consider offering RPM. That could be a good poll if we want to jump over to that. So I am curious, and I don't want to spoil the surprise, but in 2024, RPM is something that you guys are going to be able to do. But the reason I talk about it here is it's 5 years ago since this was introduced. So it took CMS a good bit of time before this one was created.
Okay, Dan, we're getting votes in. So far, only 20% of our audience has started an RPM program, while 54% have not, and 25% are planning on it so far. So I'm going to give them about 20 more seconds to vote, and then we'll close it out. But that's probably what you thought. There probably not a lot of people have done RPM yet.
Yeah, and I think one of the reasons is that as of now, the codes haven't been good, but I'll bet you the people that are saying yes are aware of some of the cool things that came out on January 1st. So I'm curious, after we talk about it, I'd love to see which groups would do it, because I think it does finally start to work in your favor. But it's interesting when I show this timeline, I just get over it. It's so crazy to think of how new stuff comes out, but you guys can't ever do it right away. But maybe they want to test it and make sure it's perfect before they release it to RHCs. But let's look at 2020.
So we're good to go.
Close out. Okay, so let's look at 2020. This is a new code that came out. Remember before I talked about 20 minutes, 60 minutes? In this year, 2020, CMS added a new code for additional 20 minutes. And so if you got 40 minutes, right, you got your first 20, and then a second 20, and then a third 20, you can get paid for that. So this is a new billing code. It allows you to bill for up to 60 minutes in 20-minute increments for patients that you have to spend more time with. And so those are the two new codes. And then a new program came out called PCM, G2064, G2065. RHCs, you could not do these codes. However, just like in the past, CMS will take all these codes and average them out to get a calculation of the GO511 rate. And then in 2021, this is around COVID time, This was primarily an RPM year. So most of the RPM changes were further clarifications of some of the requirements. Around COVID, it was a little confusing how many readings you needed to have. So CMS came out and said you need 16. This year, we were really pushing. I know I was, a lot of you on the call were, Mark, your team probably was, pushing for CMS to open up RPM to some of the clinics. And so you can see Nathan from NARHC, he shared his comments. We urge CMS to either redefine an RHC visit to include RPM and RTM services, just like other programs like telehealth, or create a G code that allow them to do both. And this isn't unprecedented, that G071 code, that's billed separately. So why couldn't they do that for RPM? And so that's kind of the 2021 focus, RPM. And then 2022, CCM reimbursements were up, and CMS provides several higher reimbursement rates. While that's good for you guys, it's relevant because it increases your rate. So remember, it started at 62, then it went to 67. And so as more programs are added, the average of all those rates increases. And so in this year, this is the highest reimbursement rate for CCM, $76 for CCM. RPM went down a little, but it didn't matter to you guys. You still weren't allowed to do it in 2022. So now going into 2023, we're at $76. So what happened in 2023? A new program called RTM, Remote Therapeutic Monitoring, was created. Of course, you guys aren't able to do it, but a new program added to the mix, chronic pain management and general BHI. Those are all calculated into the formula, and that made the rate $77.24 in 2023. And so when the feedback period came, we're very hopeful that one of these days you guys are going to be able to do RPM and RTM. All right, so what did CMS do for 2024? One thing that I'll talk about, and this does indirectly affect you, is the formula that's used to calculate the reimbursement rates has a metric called the conversion factor. And I listed what this value is. You can see in 2022, it was 34.61, then it dropped a little. In 2024, it dropped to $32.74. So it dropped about $1.15. It's about 3.4%. I will say that sometimes Congress will step in, and they have in previous years, and they can say, we're going to eliminate this decrease or offset this decrease. So it is not unprecedented. That can happen mid-year. It has happened in the past. Now, the reason the conversion factor is important is it is used in the calculation of your payment. So you take the work RVUs, there's different types of RVUs, you take all that times the conversion factor. So if the conversion factor drops, the payment that you'll receive will drop too. So this is what some of these programs look like for 2024. And you can see the drop across the board. So 99490, that's 20 minutes of CCM for the fee for service side. That dropped about $1.12. And you can see all of the CCM programs dropped. The one that's important for you is the 7168. That's what GO511 will pay in 2024. So you can see that dropped a little bit. That was about $76, $77 last year. I'll show you why it dropped in a minute. The conversion factor is only one piece. The other piece is that more components are added to the mix and they still take the averages. Wellness visits, if any of you do AWVs, that's probably at your all-inclusive rate, but across the board, those dropped a few bucks. Behavioral health, for the fee-for-service side, that actually went up. Other programs like PCM, we'll talk about PCM in a little bit. RPM went down across the board, a few, for anywhere from 33 cents all the way to $3 on one of the codes. And then transitional care dropped a few bucks too. So most of that is tied to the conversion rate, but all in all, this wasn't a major drop. There were some years where the changes were significant. This year, I would describe it as minor cuts. Again, just a few dollars in each direction. All right, so remember this rate. You want to write it down, 7168. We're going to ask you what it is later, so don't forget. This is the GEO511 rate for 2024. This will be one of the big takeaways that you want to take out of this webinar today. Let's talk about some of the new stuff for 2024. And these are new fee-for-service programs. And I know you're probably asking me, well, Dan, why are you even talking about it if we can't do it? Well, I'm not going to spoil it, but there's some good stuff, and you might want to learn about these programs. And so the first one I'm going to talk about is a new one called CHI, or Community Health Integration. And this is designed as a bundled payment to address social determinants of health. So every RHC on this call, you deal with social determinants all the time. And really, you're conducting patient-centered assessments. You're understanding everything about the patient, their life, their story, what goals they need, what are some of their desired outcomes, what are some factors that can affect them managing their care. In this program, you're anticipated to facilitate patient-driven goal setting, and that's something you guys probably already do. Many of you do this stuff under CCM. You need to develop a patient-centered care plan. It should include goals, clinical needs, desired outcomes, transitioning care. You need to facilitate that, making community-based social services and resources available. And that last bullet point, this kind of describes what is expected here. It's not limited to food insecurity, transportation, housing, access to public utilities, all of these things. If they're not managed well, it might affect the patient from managing their actual health conditions. So this program is designed to help groups like yours manage these issues. The next one I'll talk about is called Principal Illness Navigation, or PIN, PIN, and this is a bundle payment as well, and it's designed to manage one serious high-risk condition under the following activities. And you have to do, again, a person-centered assessment, understand the individual context of that one high-risk condition. So take heart failure or cancer, for example. Identify, refer the patient as appropriately to other doctors, other services. Identify supporting services, provide health education based on the patient's care plan, build self-advocacy skills, make sure the patient understands what's going on and with this condition, when they need to alert the provider or the care team, assist the patient with navigating the system. So you might be thinking, I do all this stuff already, and I have no doubt that you do, but now you have a program for it called Principal Illness Navigation. And to do this program, you need one serious high-risk condition. It has to be expected to last at least 3 months, and it has to place the patient at a significant risk of hospitalization or a decline or moving to a new facility, as long as it is expected to last 3 months and the condition is classified as serious, and that'll be up to the physician's discretion. So that's what this program is designed to do, navigate the patient around that critical condition. All right, so I know I talked about those two. I'm going to tell you why those are important later, but general care management, so that GEO511 code, I like to explain GEO511, general care management, like a big soup pot. And this is the way I think, so hopefully it makes sense to you guys. But throughout my timeline, I talked about over the years how more ingredients were added to the pot. And regardless of what was in the pot to calculate your rate, you weren't allowed to do those programs, but you got the benefits of the programs being mentioned in the code. And so this bowl of soup is a 1 serving per month. You can only do general care management once per month, and you could touch on any of the topics for those conditions. So if it was a CCM or PCM or behavioral health is in there, as long as you met the requirements, you could have billed GEO511. The challenge with how it was in 2023 and in the years before is that a clinic like yours was not incentivized to do more programs. Because you could only bill, you're capped at 20 minutes, there was really no incentive to spend 40 minutes or 60 minutes or to do behavioral health and CCM. So we've always had wished that CCM would allow you some of those extra codes, but last year they would not allow it. And so how can we improve it for 2024? Well, CMS asked a question last July when they issued their public feedback period, And I'll share with you what my feedback was, and I know a lot of you have given feedback too, but by all means, write a letter to CMS. We'll even give you a template if you need help with it, but we talked about all the clinics that we work with, and here's our proposals. So we urge CMS to expand the reimbursement beyond one all-inclusive code, G0511. We said, why can't you do the program like everyone else? If you do an RPM, do an RPM. If you do a 20 or 40 or 60, just bill those codes, and that would retire G0511. In our opinion, that was the best option. That was our comment number one. However, our alternative that we suggested was, if you're not able to do that, the ideal long-term solution is similar to breaking them up into smaller groups. So maybe a code for the initial 20 minutes, or a code for the extra 20 minutes, or even including RPM and maybe a code for the device monitoring. So we thought those comments made sense. I heard that this was the biggest comment year ever. I think there were over 10,000 comments that CMS received. So it does show that they read them. They even talk about a lot of them when they issue the findings. All right, so what was the result? I kind of gave you a hint earlier, but let's talk about it. So what they decided to do is, let's go back to our soup pot here. They put more ingredients in the soup. So the reason I talked about CHI and PIN and RPM earlier is because they are now in the mix of general care management. And the best part about it is, in the past, you were always limited to one serving or one billing instance of G0511. As of January 2024, G0511 can be billed multiple times. And if you look up some of these codes that are in there, those are the CCM codes, the PCM, BHI. So if you did 20 minutes of CCM, 20 minutes of RPM, 20 minutes of BHI, those would be 3 servings or 3 instances. So this is a really interesting way that CMS updated this. But for the first time ever, you are not maxed out at 1 instance of G0511. So what exactly does that mean? What does multiple instances of G0511 mean? Well, I'm going to read it to you just like it is in the final rule, but G0511 can be billed multiple times in the same month. Okay, and here's the part I want you to read. For different care management services, if the resource costs associated with each of the services are separately accounted for. So they don't like double dipping, but if you spent 20 minutes on RPM, 20 minutes on CCM, that would be 2 instances, assuming the time isn't overlapping. So you'd have to really spend in total 40 minutes if you wanted to do that. But this is the gray area that I talked about earlier, and I'm going to let you interpret that however you like. For different care management services, if the resource costs with each of the services are separately accounted for. So there's 2 ways to interpret that, and I'm going to give you both, and you could decide what's right. If I go back to the soup pot here, there's a lot of codes in here, and general care management is still a 20 minutes code. If you read the description, it's 20 minutes of general care management. But there's a lot of codes in here that aren't 20 minutes at all. This 99453 is for RPM setup. Our interpretation is that you would not be able to count that as a billable instance. And there's an RPM device code, 99454. That's if you get 16 readings. Our interpretation is that you would not be able to count that. So again, the big soup pot is used to calculate the reimbursement rate. But here's where it gets a little tricky. There's a lot of programs in here, like CHI, PIN, and RTM, and they're all in pot. But the reason I don't think they're worth your time yet is because you can do a lot of those in chronic care management. So remember when I was reading CHI and PIN, and it talked about creating a care plan, establishing coordinating care. Like, these are all things that you do under CCM. And so to keep it simple, because you're shooting for 20 minutes with this program, my thought would be you should shoot for getting 20 minutes of care management with as many patients as you can. So my recommendation, these CCM codes are going to be your best bang for your buck because the rules are pretty well known. If your patients are already in CCM, nothing changes for you. There is a debate, and I'm going to tell you where I land on this side of the debate, and you can tell me what you think. What about the extra code? So if you were looking at my SUPOD example here, 99455 or 99439 is 20 minutes extra of CCM. 99487 is now 60 minutes. So these are the extra minutes codes for CCM. And so a lot of people are interpreting this as, oh, well, if I'm an RHC, I can do 40 minutes of CCM and 60 minutes of CCM and 30 more minutes of CCM. And I would say that you have a good case if that is your belief. They are specifically listed under GO 511, and many people are interpreting this as unlimited extra minutes time. Remember, CMS said there's no limit. So can you do 20, 40, 60, 30, 90, 120 minutes? The answer is we're not sure. And so CMS has not specifically said that you can, and they also have not said that you cannot. And so this is an area where we expect, and I would think sooner rather than later, for CMS to issue clarity around this. However, if you were to bill that code, that 20, if you got 40 minutes of CCM and you built 2 instances of GO 511, I would say you can make a pretty good case of why you did that. We talked to the NARHC, and they've heard from some of their contacts that they believe CMS did not intend for the additional minutes to be counted in this code. And then I would ask, well, why did they list it in the list of ingredients? So it's really weird the way they did it, but I want to be fully honest with you of how it's laid out today. And like I said earlier, come to your own conclusion. I think you could justify it if you had to, but from what we're hearing, and Mark, you and your team, you're on the front lines too. You might hear some things from CMS too. So, maybe during Q&A, we could talk about this a little more, but it is something just to be aware of. So we don't want you guys to, hire a bunch of people thinking you're going to do 40, 60, 90 minutes of CCM, and then, come March or something, they issue a ruling that says you can't. But the good thing is, what we are confident that you can do is that if you hit every program group, so if you got RPM, behavioral health, let's say CHI, RTM, you could build an instance of GO 511 for each of those programs. And well, let's stop right there. Do you guys remember what GO 511 pays? So Mark, maybe we could refresh everyone's memory. Let's see if they all remember. I know we got a poll question for that. But yeah, I would encourage you guys, every instance you do of CCM is going to be that rate times the number of instances. And so you could see why a lot of folks want to do 2 instances or 3 instances of this code. Oh, we have a smart group here.
Yeah, yeah. 97. They actually listen, Dan. They're doing great. 97% have the correct answer.
Well, I did tell them all right.
Close, but y'all are doing great.
So Mark, while we're letting the poll close out, are you guys hearing the same thing as we are, that this is one area that you could make a case both ways if you really wanted to?
Yeah, I think most of the people are sort of dipping their toes in the water, but they're sort of scared to go full speed into which way to go. So I think everybody's sort of keeping their cards to their vest and waiting till CMS lets us know, and then I think the waters are going to open and people are going to really be, really know what to do going forward. So hopefully in March, they'll get this thing out. So.
Awesome.
But
all right,
yeah.
so all's looking good. I think
95% of you got the right answer, which was $71.68. Don't worry. If you're in the 5% of the 61 that put 61.57, you're still going to get credit for it. So that's all that matters. So, close it out. Thank you, Dan.
All right. Sure. All right. So that's kind of my thoughts about the extra minutes. Let's talk about a few other updates. And so in that big 2,700 page document, there's a few other things that are RHCs should be aware about. I'm not going to dive deep into them today because that's not the purpose of this call, but if any of these are applicable to you, you guys are going to have a copy of the slide, and I shared a blog that the NARHC wrote about these topics. So marriage and family therapists and mental health counselors are now added to the suite of RHC practitioners. So if you have one of those qualifications, you can generate a Medicare counter and be reimbursed at the all-inclusive rate. That is new for 2024. Previously, you had to be under the supervision of an actual provider or the doctor or the clinic. But now CMS is considering those, for all intents and purposes, RHC practitioners. There are some clarifications on telehealth. That code G2025, and this is RHC medical telehealth flexibilities, including the reimbursements for 2024. So if you use this code, I encourage you to read a little more about it. And then intensive outpatient program services, or IOP. These are behavioral health services provided through an outpatient setting. RHCs can now receive a flat payment per day. CMS is proposing as $284. So this is a service that corresponds to anticipating 3 separate qualifying services per day. And CMS is proposing that RHCs report condition code 92 to identify IOP services. So again, I'm not going to dive any further on that, but just be aware of it, and you can read more about it if it's applicable to you. All right, so to summarize, and like I said, we're going to have plenty of time for questions, probably 10 or 15 minutes, but there are some things that we're really excited about, and as a clinic, you should be too. The multiple instances of GO511, in my opinion, is long overdue. I mean, I showed you the timeline. 5 years you had to wait for some of this stuff. So we could not be happier about this. I encourage you to do this, and this is great if you have that patient that needs more services. So if you have that patient with many conditions, maybe you didn't want to do behavioral health because you weren't getting paid any more for it, you are now. And by all means, do RPM. So remote patient monitoring. I didn't talk about the specific requirements, but at a high level, you give the patient a device. We recommend a cellular device like a blood pressure monitor or a scale or a glucometer, and they take their readings from home, and the readings flow into you and your care team. And so you now get paid to do it as part of GO501. So if your patient was not in CCM, you can sign them up for GO501 under RPM only. If you do both programs, like I said, you can make a good case, and I would agree with you that you could do both programs, 20 minutes in each programs, and bill for 2 instances. The higher rate, and if you do both programs, it helps to be able to provide that patient with an RPM device. So you are expected to supply them with one, and roughly they're about $100 to $150, but again, you're making over $70 a month on this program. So if you're going to make about $1,000 a year, maybe it does make sense to buy them a cellular blood pressure monitor if they have hypertension or a weight scale or something like that. So I would encourage you to do these new programs. You don't have to go all in. You don't have to buy 100 scales. Try it with a couple patients first, see if you like it. I think your patients that want increased engagement with you in the clinic, again, these are things they do in their home. So if they want you to be monitoring them, they see a lot of value in these programs. There are some things that we are hoping for in the future. One of mine, big ones, is a separate payment for the RPM device. So like I talked about earlier, you have to provide them with a device. Wouldn't it be nice if you got paid to do that? And so I think if CMS were to make that code available for RHCs, that would be a great development. One of the ingredients in the pot I mentioned is RTM, remote therapeutic monitoring. In my opinion, RTM is not good enough yet. It's very much restricted to just a few conditions: respiratory, musculoskeletal, and you can't do RTM and RPM in the same month. So we are actively hoping that the improvements in a future release will make RTM a little better. When it is, I think it'll be worth doing, unless you specifically manage those conditions. Like if you're a clinic that focuses on pulmonology, maybe it does make sense, but it's very narrow in scope right now. So I would encourage you to wait a little bit on that one. And then there's some improvements to CHI and PIN. I showed you what they look like in 2024. I think they need to get a little better before they make sense, because like I mentioned, you almost do all of that stuff in CCM. And so until they pay you more to do CHI and PIN, I don't know that it makes total sense to do those programs as a part of your general care management. I think CCM is the easiest of the ingredients to work on. If you go with my soup example, that's always the good place to start. And then I say this one every year that I talk about this, waiving that copay. Like any Medicare service, there's a 20% copay. 1 year, I hope they get away with it and they take it off the table. We ask about it, and the answer we typically get is, in order to waive a copay, that would have to come from Congress. And we all know how fast and efficiently Congress can come to a consensus on something. So I'm not counting on it happening soon, but there is legislation out there. One day maybe we'll have that copay be removed. And so that's always the last thing on my wish list. So that's it. I know I talked through a lot in a short amount of time, but I hope it was helpful to you. I hope you got a lot out of it. And without further ado, let's open it up for some questions. Thank you.
Okay, Dan, let's do one more poll, then we'll do some questions here.
Okay.
Everybody, what new services did CMS authorize in 2024 under the CCM umbrella? This will be our last poll, and if you will answer this one, then we'll get into some questions with Dan. And you guys are voting. We've got 50% of you have voted so far. We're going to open it for another 30 seconds for you. So far, most of you have the correct answer. Let me see here. We'll wait a little bit longer. Yeah, I'm really interested in the social determinants of health. I think that's something that has probably not been paid enough attention to, because you can really tell the differences in health outcomes if you understand that and work with the people to improve that. So I think that's something that's important. Okay, we got 1 minute in, and you guys have 80% of you have voted both CHI and PIN services or have been added, and that is the correct answer. So thank you. I'm going to close out the poll, and Dan, let's go into our questions.
Sure.
Our first one here. Oh, we got a bunch of them in here. Let's see here. First one, for RHCs, do you still bill the CPT code plus the G0511 in multiple quantities? Example, RPM, CCM, RTM. Is it a G0511 times 3 in addition to the CPT code?
Good question. So you don't bill the CPT codes at all. It is G0511 times 3 or times 2. The interesting thing about that is, I walked through some scenarios on what you had to do, like 20 minutes of CCM, 20 minutes of RPM. You never specify that when you submit the claim. And so if you did G0511 times 2, CMS really doesn't know how you got there. And so my advice is always, have good documentation. If you ever got audited and they said, why did you bill 2 instances of G0511? You could say, oh, I did CCM and RPM for this patient. So you do not have to specify when submitting the claim the breakdown of how you got there. But if you're ever asked, just be ready to show it.
Yeah. Dan, on documentation, as far as like the 20 minutes of time, how do most people keep up with that? Do y'all have something in y'all system that helps track it, or how do they do that?
Yeah, in ThoroughCare we do. We have stopwatches and timers. And remember, you're counting the 20 minutes. A lot of people think it's 20-minute phone call per month, and it really isn't. It's 20 minutes of clinical activities managing that patient. So some of the things that you might do for CCM, maybe you create a care plan with the patient, and that takes 5 minutes. You update some goals. You have to call in a referral to another specialist. You do a pharmacy call. So you're counting all that time. I mean, you may be adding minutes, throughout the month. It really is not one lump sum of 20 minutes. So you have to track your minutes somehow. I mean, you could use a spreadsheet if you're that organized. There's software that does it, like ours. Some EHRs might have a way to do it. We're happy to show anyone ours if you want. But regardless of what you do, have a good set of documentation, because you won't have to submit it when you submit the claim, but CMS could ask you for it. So you build 2 instances of this. How did you get there? Show me your map, show me your work. And if you can't say how you got to 20 minutes, you could be in big trouble. This is not an area that you want to fake. You want to have a good audit trail. I would always, one thing that I'll clarify too is, for those of you on the call who have always done GEO 511 in the past, remember I said earlier that you were always capped at 20 minutes. So, today's February 15th, right? If you already got your 20 minutes, I'll bet you there are people on the call who would drop that claim today, right? But it's a different story now, right? Because you could do more things. And so the thing that you can't do is unsubmit a claim, or, you would have to appeal it. It's a mess if you do that. So best practice now is drop your claims at the end of the month. The last thing you want to do is, I submitted it on February 15th, and then next week the patient had a major issue, and we talked for a while, and geez, I now hit the qualifications for another instance. So we are recommending that you drop claims after the month ends. And you don't have to have them in by the end of the month. You have to have your minutes done by the end of the month. So you can drop it in March for February, but you can't make up minutes. You really have to do the work in the month that you're billing for. It still is a calendar month program.
Okay, perfect. Okay, that's really good advice. Okay. Okay, next question is, can a non-clinical employee make phone calls to the patient about the patient's health and count these minutes?
Yeah, I really would recommend against it. The requirements for CCM use the word certified clinical resource. And so you can make the case a CNA is a certified medical resource, or a CMA. And CMA is probably the most common that we see. One thing that I would caution you against it is, let's say your receptionist calls to schedule an appointment. They could still do it, but you can't count the minute they were on the phone. And so you could say, hey, I wanted to confirm your appointment on Friday, but you can't count it. So the time that you count needs to be clinical time counted. And that's why we suggest that you use a clinical resource for that. Now, it doesn't have to be provider time, but clinical. And the one thing I really didn't dive into a lot is providers don't have to spend a lot of time on this program. If you do use a CMA or a CNA, they have to know when they're in over their head, right? If you're talking to a patient and they're having issues with their medications, it's probably the time where, okay, hey, let me get the RN on the phone. I want her to talk to you. So know when to escalate it if you use entry-level resources. And there's nothing wrong with it as long as they're clinical, but you never want to get in the spot where they're giving the patient bad advice. It's important to know when to coordinate care, when to pull in the RN, the nurse practitioner, the PA, the provider. Remember, all of these services fall under the provider. The provider's NPI number is on the claim. And so your staff is providing the services under your supervision. So we highly recommend providers review those care plans. I mean, look what's being discussed. And that is best practice, that the provider doesn't have to do the care plan, but would it be helpful if the provider spent a few minutes looking it over? Yes, and that time counts too. So at the end of the month, when the provider spends a couple minutes looking over all the care plans, you're logging minutes. And so that's a good way to get minutes towards the end of the month. The minutes don't carry, by the way. So it's a calendar month program. So if you got 15 minutes in February and then the first week of March, you got 5, does not carry. On that first day of the month, you're starting fresh. So you never want to leave a CCM at 15 minutes. I would always find a way to come in at the end and add clinical value to that patient. So let's say I can't even get the patient on the phone. well, hey, I'm gonna start putting together their care plan for next month. And I spend 5 minutes doing that. Now I've documented, I have the proof, and I got 20 minutes. So I know I rambled a lot.
No, that's fine. All this stuff is great. I mean, it's really helpful to our RHCs out there. It's helpful for me to understand this as well. Okay, and this person is sort of like me, a bit confused. Can you bill a 99454 under the new rules? A 99454, which I do not know even what that is.
Yeah. So a 99454 is the RPM device code, and so RPM on the fee-for-service side is made up of a few codes. One for educating the device, educating the patient on how to use the device. One is if you give the patient a device and they get 16 days of readings per month, and then the other is if you get 20 minutes. GO511, if you read in the description, it is still a 20-minute code. It says 20 minutes of general care management. But when I go back to my soup pod example, the person that asked the question is correct. 99454 is in the mix. So could you make the case that if the patient only got 16 days of readings, can I bill a GO511? And I would say you could probably make that case. From what we hear, again, nothing is in writing. You know, we talked to NARHC about this. We talked to other groups about this. Our thought is that CMS would want you to get the 20 minutes of RPM time in order to build the RPM codes. Again, this is why we're so anxious for CMS to come out and clarify. But since they haven't, I think the person who asked the question, if you felt strongly about it, you could probably justify it if you had your documentation. But again, I don't want to be the one to advise you on it, but it makes you wonder, why would they list it in the mix? I mean, they specifically listed it. They went out of their way to list it. So why would they not allow you to bill for it if you've met its qualifications? And this is the confusing part of why CMS did it this way. You know, I shared my proposal. I thought they should have 3 different codes: a device reading code, a 20 minutes code, an extra minutes code, and they didn't really go with it. But that's my advice, Mark. I don't know if you feel strongly one way or the other, but
no, I rely upon experts like you on stuff like this, and they never pay attention to anything I say either. So don't feel bad. So,
but see, that's what I said earlier. Look, if a couple hundred of us all wrote in the same comments to CMS, you know, wouldn't that be cool if? Wow, every RHC.
And I will do it. I know we've got a bunch of folks in Washington right now that are lobbying. I should have gone up there, but I just didn't have time to do it this year. But the National Rural Health Association, they're having their policy thing this week. Okay, next question. Right. Just to qualify and I think you've already answered this question, but we'll go ahead and do it anyway. Just to qualify, at the end of the month, the G0511 would go out with a quantity based upon minutes spent. I mean, I think that you've already answered that. Yes, that's what they're going to do.
The quantity, I'll just clarify minutes spent, you know, the quantity of programs accomplished, right? So if you completed 2 objectives, you can bill for 2 instances. If you did CCM and RPM, BHI, that's 3 quantities, right? Again, the minutes is the gray area, right? So if you build 1 instance at 20, you know, right now I said I'm on the fence of if I would count the 20 extra, but let's say the person who asked the question, if you were asking if you got 40 minutes, technically, you know, you could say that's 2 instances. But yeah, you specify the instances at the time you build the code. That's why I don't submit it every time you complete one, right? So in my example, you don't want to submit one on the 15th and then one on the 29th, because your 29th one's going to get denied. It's going to say you've already submitted GO511 for the month. So you have to submit the quantity at the time you submit the code. And that's why I said don't do it earlier, because you're going to waste your chance if you hit that next instance, right? And you wanted to increase the quantity. You'd have to deny the claim, resubmit it. It's a mess. So I always say just wait. And that's my advice for RHCs. You know, you may think you're done right now and it's mid-February, but you don't know what that patient's going to do next week. I'd hate for them to call you. They have a big medication issue. You devoted a lot of time to it. You know, that might have pushed you up to the next tier.
Okay, next question, and all these questions are pretty similar, but I'm just going to ask them anyway, just so you can give us any nuances, because it's great. So can we bill GO 511 once a month with multiple units on one claim?
Yes.
Okay, that's what I thought.
It has to be on one claim. Yeah.
It has to be on one claim. Okay. Is that once per month for each service? They're probably, it sounds like they're talking about CCM and RPM and all that sort of stuff. So
yeah, it's once per month, and at that time combined all your services as instances, right? So remember, even though all those codes are in the pot, the only code you'll ever bill for is GO 511. If you tried to bill the others, they wouldn't work. They would say you're an RHC and you can't bill those codes. Remember, you guys get paid totally differently.
yeah.
The AIR, I think they kind of kept it going where you guys are in different payment models, but it's once a calendar month, right? And typically what groups like to do, if you bill at the end of every month, then you're also usually keeping 30 days between your claims as well. But these codes are typically a calendar month code. So once a month per patient, at the time you submit, choose the number of instances.
Okay. Again, pretty similar question. So if there's enough documentation to bill 2 units of a G0511, do we bill on one line, or one line with 2 units, or individual lines?
One line with 2 units, I believe, right, Mark?
That sounds right to me. I'm going to defer to you, but that sounds exactly what you should do. One thing to remember
you're changing the quantity.
Mm-hmm. One thing to remember too is chronic care management services are not a part of your all-inclusive rate calculation. So this will go on the cost report as a non-allowable expense on there as far as computing the all-inclusive rate. So keep that in mind, is this could have an impact on your all-inclusive rate. So you'll need to do a little studying, but just make sure that you know that it could lower your AIR, and take a look at it at the end of the year so you don't get any surprises. That would be my recommendation there.
Mark, one interesting thing too, and your group can help them with their cost reports, but let's say that, right now it's not clear that CMS would reimburse you for that device. So let's say you bought 100 blood pressure monitors, that's a capital expense, right? That can be included when you do next year's cost report. So it's costing you a little more to run your clinic. You're buying a device for a program that you're going to be managing that patient to. So while it's not really related to GO 511, if you wanted to use that program for RPM, you could, include the cost of the device when you do your reporting.
Okay, that makes a lot of sense. So okay, perfect. Next question: do the different GO 511s require a modifier to show that they are separately distinguishable, like a modifier 59? And
I am not aware. I'm not aware of any. Again, this program is so new. I mean, the people that submitted in January probably haven't even got their payments yet. So I think we're going to know one way or the other. I haven't heard that any claims got denied because they're missing a modifier. But as of right, does anyone know, by the way? Has anyone got a paid one? And that'd be interesting. If you have, write in the comments. But it's brand new, this program. So I think we'll all learn more and over the next couple of months. But I'm under the impression that you do not need one.
Yeah, that's what I would think. I definitely know it would not be a 59. That would be, that's not something that you would use for this. Okay, so can we now bill LPC under themselves without being billed under the provider? I don't know.
LPC? I'm not sure what.
Yeah, licensed professional.
That was one of my bullet points. I had a slide on that a few slides back. Here, let me go back. Yeah, this one here, I think they're talking about. It was more on the intensive outpatient program, having different qualifications of providers and the counselors and therapists. So I don't know. That's probably a little different. I'm probably not the one to ask about that, but we could
Yeah.
probably direct that person to the right answer.
Yeah, that doesn't sound like a CCM question. That sounds more like a general billing. I mean, typically, the way rural health clinic bills is you bill on a UB04 to Medicare in field locator 56. You're going to put the group MPI number for the RHC, and field locator 76. You're going to put the MPI number of the provider that provided the majority of the service to that patient, which would be probably the LPC in this case here, if they were the majority provider. So that's where you put that LPC number.
Okay.
Okay. Next question. How best would a provider-based RHC track their cost for those added fee-for-services that would need to be separately carved out? Ooh, that's not like a Mark question there. I mean, Dan's gonna, if you use Dan's software, number one is that they're gonna track their time for you. And what we would do is we would take that amount of time and multiply it by the hourly rate of whoever was doing it. And then we would reclassify that expense to, there's a line number on the cost report, I think it's 80. So cost report is CCM services, line number 80. We would put it there, and that would exclude it from the cost of the all-inclusive rate calculation. That's what we would do. We put any type of fees. If you have an outside company that's doing your CCM, we would reclassify it to that particular line and disallow that cost on the cost report. Okay, next question. Will you provide the slides? Yes, they're in the handouts, they're on our website, they're in the Facebook group. I will send out the slides tomorrow. There's about 623 of you signed up, and thank you for about 400 of you that actually showed up today. But we will send out an email tomorrow with the recording of the presentation and the slides for everybody that's registered. Let's see here. And we'll go a couple more, and then we'll close it off because we're over time. If we bill GO511 multiple times in a month for the same patient, are there additional codes and descriptors I need to add distinguish which program I am billing under G0511? I think you've already answered that. You only bill it once a month.
Well, it's once a month, but you do the quantity at the time you submit it. So, definitely don't do one instance now, another instance later. It's all on the same line. But I do think the question is, I thought initially they would have you specify how you got it in the claim. Okay, I got a 99490 and a GO4, they don't care. You don't have to specify it when you submit it. So you'll submit 2 instances. Again, the only way you'll have to explain it is if you got audited. And they said, you billed 2 instances in February. How did you get that? And then you got to be prepared to show your work if that were to happen. But at the time you submit the claim, you are not getting to that level of detail. It's just number of instances.
Okay. If we provide an RPM device to a patient, then how do the results come back to our office? Can we just call the patient periodically for the readings and then count that towards the service? I would think, and this is me being just dumb, is they're going to send this stuff to you automatically through a portal, and you can monitor it that way. Is that correct, Dan?
It is, yeah. So RPM is about digitally sharing the readings, and so the reason you give the patient is a device, is that you can monitor them. If you had to call and ask them, that would not be RPM at all. That would be checking in with the patient. And so what you want to do is give a device that has the capability of sharing data. A lot of them have portals. They would have to give you access to the portal. You could use a software like ThoroughCare. If you do, the readings come into our platform in real time, and you can view them. And the other thing you could do is you could see who's not taking their readings, right? So I gave you a blood pressure monitor, you haven't used it all week. Why not? What's going on? So you definitely want to use a system that the readings can be sent to you in real time, either your EHR or a care management software platform like ThoroughCare.
Okay, we'll do 3 more questions, and then we'll close it out. We'll do 10 more. Because this is one we get all the time. How common is it to see MAs providing a CCM service.
It's the most common resource, but remember, they're working under the supervision of the provider. So providers on the call, just make sure your MA is comfortable. You're asking questions. How's everything going? How's your care plan? How's your medication? So an MA can definitely do that, but they have to know when it's out of their scope of expertise. So you're having a reaction to that med. Well, hold on, let me get the RN or let me get the doctor. So just make sure you know when to get an appropriate provider. But the majority of the minutes logged from what we see is MA time.
Okay, next question is, do you or anyone on call know the best way to remove the copay barrier? Because many patients refuse because of this. Dan, I'll give you my 2 cents worth on this one.
Yeah.
Is rural health clinics are one of the very few services from Medicare that there's no what's called lesser cost of charges. So you can actually charge a low charge, and so right now the rate is $72. You could charge them $50 a month, and their copay would be 20%. That'd be $10, and you could actually receive more money than your $50 charge. So I would be very careful to try to charge as low a number as reasonably possible for these services each month. Dan, what would your comment be on that?
My comment is you have to charge it. So I always get the question, can I waive it?
Yeah.
Well, no. And I'm going to be very careful what I say here. Yeah. You have to bill it. You have to set them a bill. Now, the question is, what happens if they don't pay it? We have doctors that say, I don't care. They need this service. They're going to be better off with it. You may say, I'm never sending this patient to collections. So eventually the bills are going to pile up. You have to figure out what to do. But I think the program is more about the money to me. I mean, we've seen some clinics that say, look, 90% of my patients are comfortable paying it. I don't want those 10% to cancel. They really need it. They're going to end up in the hospital without this program. I'm offering it anyway. So I have many clinics that do that. But you are not allowed to not charge it. You can't waive it. You would get written up for that. CMS would probably not like it. But again, it's up to you how far you want to take it. My thought was, if I have a needy patient, I don't want them to quit the program, right? I get more value out of them staying managed than quitting the program and then having to check in with them in the hospital. So that's just my thoughts, but I still hope one day Congress is going to eliminate that copay. I don't know why it's still there. It's ridiculous.
Yeah, right? It definitely should be there. That's eliminate that copay, just like they do it for preventive services, and this is basically a preventive service, because if you're monitoring, somebody, it's going to keep them out of the hospital. I know I've got chronic heart failure, and I mean, I am monitored so close, and I haven't been to the hospital in 6 years. And so, but that shows that it works. And so, okay, one last question, and then we'll let Dan get out of here. If a patient is receiving CCM with a DX and with a diagnosis of hypertension, HTN, I guess that's hypertension, I'm not sure. Could they also receive RPM due to HTN? That too many abbreviations for CPAs by there. But Dan, do you have any idea how to answer that question?
Yeah, I do. So I think it's less applicable for RHCs, but on the fee-for-service side, you have to be careful which conditions overlap. So I'll give you two that overlap a lot. Like there's a behavioral health program, right? And so let's say you were managing the patient with anxiety in the behavioral health program. CMS would not like anxiety to be one of the two chronic conditions because you're already managing it in another program. For RPM, it doesn't really work that way. You can use the same conditions. So you could be diabetes and hypertension for CCM, hypertension, give them a blood pressure monitor for RPM, because it's a different type of service, right? It's a service where you're monitoring data. It's not an overlapping service. So where like BHI and CCM, you could say, well, we're covered in the exact same thing, can't overlap. So the example that was given, totally common. In fact, hypertension is probably the most common example for RPM.
Okay. Well, Dan, we'll let everybody go. We're at 15 minutes over. Thank you very much ThoroughCare, if you haven't started your CCM program, to me, they're the leader in the rural health clinic market. I see them everywhere. I see them at our meetings. That's why we got them to do this, because we think they're the best. If you don't, and if you want to learn more about the services that can be provided, just go to YouTube and subscribe to their channel. I watched their channel. I listened to it on the drive to someplace.
Yeah.
5 hours. I did 5 hours of Dan and his group, and they're all fantastic. So
Yeah, Mark, and I appreciate that. If you go to ThoroughCare.net, we have hundreds of articles. You don't even have to be a customer. I mean, you could read all of our articles for free. Things like how to hire a care manager, how do you bill for these programs, how to set this program up. There's videos and articles. So use whatever you like. They're free, no obligation. Our goal is to help as many clinics as possible, even if you use this or not. In our opinion, the programs are incredibly valuable. And the point of my presentation is they're really good for RHCs this year. You saw in the past they weren't always. So I'd encourage everyone to do it. But it was a great group on the call today, very interactive. I'm excited to have spent my day with all of you. So thank you for inviting me.
Okay, Dan, thank you very much. Thanks, everybody. Bye-bye.
Bye, guys.